Hi, everybody. I am Dr. Rachel Rubin. I am a urologist and sexual medicine specialist, and I have a treat for you today. So, as a sexual medicine specialist, I treat a lot of menopause. Why? Because menopausal complaints are not just hot flashes and night sweats, but we see so many sexual health problems: genitourinary syndrome of menopause, low libido, pain with sex, arousal disorders, orgasm disorders. Menopause can come with a lot of sexual problems. And I am joined today with just a superstar in the menopause field, Dr. Stephanie Faubion. Introduce yourself to our amazing listeners.
Hi there. I'm really excited to be here. As Rachel said, Stephanie Faubion. I am director of the Mayo Clinic Center for Women's Health and medical director for the Menopause Society.
That is a very short introduction for a very impressive person who really is an authority. If you ever read an article about menopause, I asked Dr. Fabian, she must spend 100% of her time just talking to reporters, but it's really important because menopause is having a moment. We can't go without seeing a headline, an Instagram story, or something. Certainly my feed is full of menopause information. So why do you think menopause is having a moment right now?
I think it's a well-deserved moment and should have happened a long time ago, but I think it's having a moment for several reasons. I think the generation of women experiencing perimenopause and menopause is different now, and they are less willing to suffer in silence, which is a great thing. We've also created a little bit of a care vacuum in that the Women's Health Initiative study came out in 2002, and after that, we really left women with few choices on what to take for their managing their symptoms, and it's created a vacuum. And after that, clinicians decided they no longer needed to worry about being educated about menopause because there was really nothing to do for menopause if we weren't going to use hormone therapy. So I think where we've come to now is women are having symptoms, they're having a problem. It's affecting all aspects of their lives, their relationships, their quality of life, their ability to work. And they're saying, hey, this isn't right. We need to do something about this. And there's still very little research in this area. We have a lot more to do, and they're demanding answers, as they should.
As they should. And we have a toolbox. We have quite a lot of tools in our toolbox that are evidence-based, that really work, that help people. And as I always say to my patients, I say, you have a generation of clinicians who were not taught how to do this well. And hormones are not all good or all bad, all right or all wrong, but they require sort of some understanding of when to use them, how to safely use them. And that way you can avoid your patients going to the snake oil salesman down the street who are using non-evidence-based sort of treatment options. So one article that came out recently this year that I thought was really fascinating was this concept of what we're calling NFLM, not feeling like myself. And I will tell you, I think it's brilliant because there is not a woman 40 and above who doesn't deeply connect with the idea of NFLM, not feeling like myself. So can you speak to the symptoms of perimenopause and menopause beyond hot flashes and night sweats? I named a few sexual symptoms earlier, but how we're really learning about all these new areas of sort of really understanding what is perimenopause.
This is such a great question because very rarely does a woman come in and say, I have hot flashes. Well, is that all you have? Yep, that's all I have. I just have hot flashes, a couple of hot flashes. That almost never happens, as you know. So menopause is not just about hot flashes, although that's one of the most common symptoms. The hot flashes also occur at night. We call them night sweats when that happens. But there's the sleep disturbance, which is probably not just related to night sweats, but is related to a lot of other things as well. Mood symptoms can be crazy. A lot of women come in with really descriptions of irritability, just not feeling right, anxious. Another one that we're learning is one of the more common symptoms is joint aches. So it's important to remember when we're talking about these symptoms that estrogen impacts every tissue and organ system in the body. And when you lose it, you have effects in pretty much every tissue and organ system in the body. So it's not just about hot flashes and night sweats. And we've also learned that recently women in perimenopause have the same symptoms that women after menopause have. So it's not just that it starts at menopause.
And one thing that I want to make clear, and this is really important because this is often this is going to be geared towards the primary care world. And I think that the way medicine is set up, of you're allowed to have one problem. If you have more than one problem, I don't know what to do. You go in the crazy bucket of we're not interested, or we don't have time to take care of you. But menopause is never one problem. And so the disaster here is these people are getting diagnosed with a mental health condition, with fibromyalgia, with dry eye, with sexual dysfunction, with depression, anxiety, and they're getting 10 diagnoses for what is actually one underlying hypogonadal problem.
That's exactly right. I've seen a woman at the Mayo Clinic who came to me as a general internist, not even knowing I did menopause. So she was coming to me, traveled across the country to come in because she's gaining weight, she's losing hair, she's sweating. She thinks there is something horribly wrong with her, like must have a cancer or something. And when you put this all together, the palpitations that she's having, all of this, it was all menopause. And think of the, just the expense to come to the Mayo Clinic and be evaluated for that. But no one, including her, had put together the fact that all of these symptoms were related to menopause. So you're exactly right. Sometimes women don't even recognize that it's all related.
So the primary care people listening, this idea of we were raised on hormones cause cancer. Can you speak really of sort of what is the data in 2024? Am I going to die if I take hormone therapy? Am I going to risk blood clots and horrible cancers? Like, what is the data?
That's such a great question. And while I could go on for an hour on the data on this, to be brief, I think we now know who the best candidates are for hormone therapy, and we can really minimize risk. But we also know that there are differences between the formulations that we use, the routes of delivery that we use, and the doses that we use. And we can really individualize this for the individual woman. So when it comes down to cancer risk, as you know, if you have a uterus and you're taking both an estrogen and a progestogen, the risk of breast cancer has increased slightly. But when I say slightly, I'm really talking the same as between 1 and 2 glasses of wine a night, the same as being overweight, the same as being inactive. And we're really talking about less than 1 case per 1,000 women after about 5 years of therapy, less than 1 case per 1,000 women per year after about 5 years. So it's a very small increased risk. The risk does not appear to be increased when women are using estrogen alone when they've had a hysterectomy. So blood clot risk we can really minimize with using a transdermal or through the skin preparation of estrogen, and particularly so with the lower doses. So we're really now we don't see that the risks are prohibitive for most women, and most women who are having really bothersome symptoms usually can take an estrogen type product safely.
And I think it's just really important that, we can learn new things, right? With the introduction of GLP-1, which is also very fascinating, using those in perimenopause and menopause, but how much better they could potentially work. As I tell my patients, if we fill your gas tank a little bit, because it's very empty right now, right? Not having hormones, it makes your gas tank empty. Then add your family and you're taking care of aging parents, and then you have depression and anxiety, right? It's going to empty that gas tank. So the idea of, again, a GLP-1 deficiency, right, may be increased as you go to perimenopause and menopause. But by adding back hormones, can you help with keeping muscle around, keeping mental health better, keeping bones strong, because osteoporotic fractures kill way more people sort of than breast cancer does. So as a primary care, how do we learn how to write the prescriptions? How do we learn how to counsel patients properly? Do I have to go back and take a fellowship? Like how do I learn how to evidence-based integrate this into my practice?
Great question. Some of the easy things to do to gain confidence in this is take a course. For example, the Menopause Society has an annual meeting in Chicago in September, and we do a 101 Menopause 101 course tagged onto it. It's also available online. We're actually having another one of those Menopause 101s at our Mayo Clinic course in Washington, D.C. next week. But there are ways to get this information and in a digestible way to where you can learn the how-tos of here's what I need to do, here's where I start, here's how I need to follow it up. It's really not that difficult to get into this. And as you made a point about the GLP-1s, I mean, we all have to learn these new things every day because the treatments for things change, drugs change, et cetera. While hormones have been out there for a long time, a lot of people may not have ever had the experience of treating menopausal women. But I would put a plea out to my primary care colleagues in internal medicine and family medicine that it is you that needs to be doing this, because think about it. You already are the expert on brain health and bone health and heart health. You should be the most comfortable in dealing with hormone therapy that has impacts throughout the whole entire body. So it's important for us as primary care providers to really have a handle on this and to be the owners of managing menopause for women in midlife.
I couldn't agree more. And as a sexual medicine doctor, treating menopausal women is actually what fuels my soul and stops all burnout because they get better. And I see, all of my clinic is full of 50-something-year-old people who come back and they say, sex is good. My relationship is good. I'm kicking butt at work. I have a patient who just started law school because she feels good. And she goes, I'm keeping up with the 20-year-olds. It is incredible to watch people who feel terrible and then watch them blossom and get better. There's nothing that fuels my soul more than these patients. So what is exciting you in the menopause world and the data in what we're learning? Because we still have so much data we need to gather. What is exciting you right now? And what are you hopeful for sort of down the road with some of these new initiatives coming out?
Wow, a lot of things. So, well, one, the fact that we have a president of the United States who is interested in menopause is amazing. The NIH is more interested in looking at menopause as well. So I think it's an exciting time that there's more interest and more research funding that seems to be available for this. But in terms of clinical management, we now have so many options available to women. We've been talking about hormone therapy, but we now have non-hormonal medications out there as well that are on the market. Fezolinetant is an NK3 inhibitor that came out last year. There's probably another one coming out in the next year or so. So women have lots of options. And for the first time, we can really individualize treatment for women and look at what symptoms are bothering them and how to best, go about getting women back to where they should be. We're also starting a Menopause in the Workplace initiative with the Menopause Society and really kind of tackling that one. We know that a lot of women are missing work or not taking a promotion or, avoiding a leadership role because of their menopause symptoms. And we should never be in the position, women should never be in the position of compromising their work lives because of menopause symptoms. This is something we can help women with. So really excited to have that initiative as well.
I am thrilled to talk to you. I think our big takeaways is, believe your patients when they come to you and they've driven and they've parked and they've got childcare and they showed up to your office and they waited to see you. And when they're telling you that they have all these symptoms and they're not feeling like myself, maybe before you jumped straight to the SSRI
or say use a fan
or say, just do some yoga and deep breathing. Maybe we really dive into that menopause literature, really understand the pros, the cons, the risks, the benefits. We do it with so many other things. We can do it with hormone therapy as well. And it is not a one size fits all. We do need to talk to our patients, customize the care, and really figure out what do they care about, what do they want. And patients are able to understand risk and benefit. They, of course, can make good decisions for themselves. So I am so thrilled. I hope to have you back again to talk about the nitty-gritties of hormone therapy. This was just a quick rundown. And thank you, everyone, for joining us. And thank you, Dr. Faubion. This was so excellent.
Thanks for having me.